Ladies and gentlemen, please allow me to welcome Mr. Richard Ballerand. Richard is a lay member and multi-board advisor to the NHS and outside the NHS. And we're here today to talk about the digital health transformation and the era of digitization. Hi, Richard. How are you?
Hello, thank you for inviting me.
So in general, what are your thoughts on the topic of digitization, especially in terms of the situation we're currently facing with COVID-19 and this era?
Well, it's both a broad topic and quite critical. I mean, I should state in the beginning that I'm neither a clinician or a data scientist. My original background was military and finance, but I've been involved with multiple PPI, well, patient and public involvement groups, over the last 5 years in particular. And of course, one of the major issues that patients, public, carers, everyone's concerned about is how digitization is taking hold and how it can benefit us and how it's potentially distresses people. So I'm very interested in the matter, and it's something that needs attention. I mean, I've been involved at local level as governor of several hospitals in my area, as regional level, and remember my region, London, it would probably rate about 10th in the European Union in terms of economy or population, so it's a large region, and of course also nationally and at EU level. So I mix with lots of groups. It's been very much a full-time job, as it were, in the last 5 years, and I constantly talk with pro-data groups, pro-privacy groups, because there's this creative, how should I put, stress between the two, and I don't say fortunately, because there are a lot of people who have suffered, etc., and I feel for them, but there are advantages in this situation that we've been forced to uptake things that many people have wanted to introduce, and now it's a question of just making sure that they continue and they're introduced correctly. And it's all very well to have technologies that are ideal in the theoretical constructs, but one, they have to be communicated to people. Two, they actually have to be taken on board by people, and three, actually accepted, and those are quite important stages. So it's very important that we get this right, because if you upset the population, that could be local communities or special interest groups nationally, then they will block any real achievement taking hold. So in a sense, we must take advantage of this situation we find ourselves, where people have basically been forced to do, to go digitally, and it's happened very quickly.
Right, absolutely agree with you, and there's a big fight in those ideas. Would you perhaps maybe elaborate on some of these disruptive or cutting-edge technologies that are currently being used to advance our fight against the coronavirus?
Well, let's see. I mean, there's so many of them. I mean, they're technologies that were already around, things like telemedicine with online health consultations, remote monitoring of patients, all the sorts of things that for some people suddenly they have to zoom in all the time, and they didn't realize this was possible, but it's been possible a long time. I'm part of a group that's actually trialing augmented reality conferences, etc., which it's quite interesting. I imagine the summit here, you'll be quite interested in that, because there's a lot of potential there. I mean, we already do sort of remote surgery, all these sorts of technologies are sort of there, and they're improving. But we did have a lot of resistance, both patients, clinicians, because people don't like change, and all this is disruptive. But even previously, it's not as though things had to happen. I mean, I've long been an advocate of this on the basis of financially. We have different health systems, but in the United Kingdom, it's very much stressed, has always been stressed financially. So there have to be better ways and more efficient ways of actually using our scarce resources. And the trouble is, if you try to introduce something on the basis that this is to financially improve things, people say, no, you're just saving money. So in a sense, suddenly they realize this has been introduced to actually save lives, and they're much more amenable to the change. So I mean, there are other things that come in line which people forget. Both accessibility, because although I've been on, for example, I chair the Patient Public Voice group of the London Clinical Senate, which looks at changes in systemic changes in London. And I remember the first thing that the people would say, "Oh, I can't use this technology because I have sight problems." And then of course someone would say, "I can't use this technology because I have hearing problems." And I say, well, what we need is a technology that deals with both, because in a sense that's what technologies can do. And of course some people say, "Well, I can't even sit in front of a screen." I say, well, eventually, if you can concentrate things where people the technology optimizes their interaction with health, then you're actually able to give more time to clinicians to actually deal with people face to face that can't work through a system. But you do save immense amounts of time, and it's far more efficient. And there's so many things. I mean, the side, how should I put it, side issues. In London, I think in the UK they calculated that 5% of carbon emissions were actually due to people going to NHS appointments. And I've talked across the board in various fora where the clinicians at hospitals say, well, 80% of the people probably don't need to come here. We could actually just tell them, yes, if there's no change, that's good. But we do need to see people more quickly when we really do need. And the great thing about these technologies is they enable people to, one, be monitored, but two, you can flag up more fields, for example, in a project I was involved with. I mean, they now it's quite feasible for the high street optometrists to sort of view people's eyes, and they can immediately send someone with the very highest priority to Moorfields, which is a world centre for ophthalmology, and then they don't need to come in. But sometimes people don't come in. They can pick up these outliers that you wouldn't have noticed otherwise. And of course, you mentioned, earlier the amazing changes that are going on both with artificial intelligence and machine learning, its subset. And it's all what's quite interesting, I think, particularly when you apply it to what's going on now, is that this forcing ground of the coronavirus or COVID-19 has I think the word of the day probably you could say is pivot, which means that suddenly you've taken all your resources, etc., and you're putting on dedicating to one thing. So you're switching out, and that's been quite effective. I mean, I just think as I say, I'm not a data scientist, but a few months ago I was appointed to the Health Health Data Research UK's, which is our National Institute for Data, or wants to be. Um, they have an improving and uniting delivery group. I love the acronyms in health, but anyway, so IDG board essentially, which reports to the overall board, and they've been working phenomenally because they've got 8 hubs and multiple gateways.
Right, you're absolutely right, and you brought up a lot of great points. The last part you mentioned governments. What are your thoughts on government regulation in this case with such disruptive technologies and technologies that are moving so quickly? Are they fast enough to catch up with them?
Well, is any government organization fast enough to catch up? I mean, it's whether it catches up satisfactorily, I think. I mean, already I've got involvement with the UK and the EU regulatory agencies, the EMA and the MHRA, and also NICE, which is a rather strange entity and is probably considered the jewel in the crown of the NHS. When I travel internationally, whether US or Europe, they all say, "I wish we had an organization like NICE." I mean, well, I assume National Institute for Health and Care Excellence, because of their leading role. And of course, although they've been very much in the vanguard of things, they've been constantly changing and trying. And at the moment, we're involved in a project which is trying to change their methods, trying to change the protocols for assessments of quality of life, for assessments of medications. So it's these changes, they're already continuing, and it's a function of how good they are. I mean, I can say I did pose this question the other day to Amy Abernethy, who's the principal deputy commissioner at the FDA, and I just asked generally whether we would the spirit of cooperation, which we've seen all around, scientists sharing things quite quickly, seeing things through preprints. I mean, there are problems sometimes if you don't actually check these sources or have them, peer reviewed, but still, speed is of the essence at this point. Um, and I was saying, well, are we going to continue? She said, well, we've already started. And I said, yes, started, but you need to coordinate more because it's quite easy to coordinate in a sense. It's just the checks and balances must be maintained. So I think, the organizations I'm familiar with from MHRA, EMA, NICE, and the FDA are, yes, they're working quite hard, but they're often very large organizations, and there are a lot of this comes also from the pharma companies because there are certain things you could do which would expedite. We're sort of stuck with old models, as it were, of protocols, the way things should be done, even the number of interventions. Everything can be speeded up. I mean, whenever I talk about speed, people say, "Oh, well, there's that Zuckerberg quote, move fast and break things." Well, the point is to move fast and preserve things, and that can be done as long as that's what your objective is. So I'm confident. I mean, I see this across there are a lot of good people in each of these organizations trying to implement the changes, and of course it's implementing the right changes. But the great, and it's again falling back to AI ML, the great thing is that we're now able to do things that we could never even envisage before because the great data sets can be analyzed, they can be paired, and and the data is much cleaner than it used to be. So in fact, I think, yeah, I'm hopeful that they will move forward. Mind you, any organization will not want to move if it doesn't have to. So this has been a bit of a kick in the pants to some of them, I think.
Right. Once again, a lot of great points. Would you say after, well, I guess once this era of COVID-19 finishes, which I hope is sooner than later, of course, would you say healthcare would have seen a lot of fundamental changes at that point?
Well, definitely, as I say, I mean, just thinking back to linking with the previous question, I mean, the things that are happening and will happen more are system reorganization, enhanced collaboration, streamlined data collection and analysis, and of course, once this is a given and it's incorporated, I mean, we have, for example, in London, we have very advanced hospital systems. They what we call global digital exemplars, but they until recently they were unable to communicate from the notes from one department to another, and heaven knows what happens in sort of countries that have more challenging IT environments. So this is what it's I think that, I mean, there are other things that are afoot, as it were, in terms of the priorities that are paid, for example, to in hospital health versus primary care. And of course, the handmaiden, poor child of all this prevention and public health, which was very much in the margins of things. I mean, everyone gave it lip service, but in terms now they're suddenly recognizing that yes, public health is a good, and not only that, if you don't get it, then everyone suffers. So that's why I think it's so challenging in the United States because they don't have a public health system, and it's sort of fallen in on itself because it was geared to uh, possibly a possibly a majority, but possibly a minority, but not a great majority of the population, and they're suffering because in a pandemic you have to treat everyone, and of course it's there are all sorts of issues which are actually much deeper, as it were, than COVID-19. But have to do with healthcare inequalities over populations, racial groups, etc., which is this is primarily social or political social. So, and of course, we see, I mean, as I say, in the United States, where I am now, there are multiple viruses afoot. I mean, there's the coronavirus, and of course, you've got the virus of racism, the virus of poverty. All these things are there, and they're coalescing, which is why I hope that we will pull these improvements on with us, because step change has already occurred. It's a question of making sure it goes forward, And particularly, as I say, again, from my own experience, so much more money goes into. I'm on different boards that, say, for example, oversee funding applications, and of course, now it's sort of understood now that there should be patient and public input to these things, because there's no point having them afterwards, because then just you'll have a lawsuit and complaints, and people will suffer, which is the ultimate problem. But now that's been taken on board, yes. So we turn down proposals that don't have serious input, but you get responses from those researchers saying, "Oh, well, actually, things are much better because they're actually able to fine tune their projects, and so so that's been improved." And but that was already. But I think all these other things will continue away. But I think it's necessary that politicians, well, they're very 5 month-ish, or they think they look into the next quarter or possibly the next year, at most the next election, and beyond that they're not really that concerned. They're trying to stay alive, I suppose, politically alive. But yeah, I think definitely this. But that's why you need organisations like yours and conferences like this for people to communicate, network, and actually ensure that the best is embedded and we continue with it, because there are a lot of groups. I mean, well, I shouldn't mention countries, but I mean, the United States, they're people who wander around and cough in other people's faces on the basis that they believe that this is some sort of democratic host. And yes, one could say that yes, if you're being very clinical, the lethality rate of COVID-19 is not that high. But the point is that we should be preparing for one. This wasn't a black swan event, in terms of something that couldn't be expected. It was all expected. It's been very expected. But what shocked, I think, and that's speaking to epidemiologists who know, is the speed of transmission, how quickly everything happened, and that's upset a lot of countries. I mean, it's amazing to think that the two leaders in public health epidemiology were the United States and the UK. And there's definitely, well, they're leaders in something else now, which is sad for both their populations, and that's to do with the implementation, speed of implementation, etc. But as I was saying, we have to take on board all this, because there will be more pandemics. There's also the spectre of antimicrobial resistance, and we might get another pandemic. I mean, there's always the fear that you will have a mutation of this pandemic, and we'll have a second wave, like the one in 1918, which went from a bad flu to 24-hour dead for young people. So that probably won't happen, but there will be other pandemics in the future. So we need to be prepared, and we need to adjust our health systems, because all the what people are so upset, and I wouldn't recommend anyone protest, because that's the best way to transmit what we have. But on the other hand, it's highlighted how unhealthy certain groups are, and the fact that they're marginalized and they're not treated, and now it's coming back to bite the countries that have just ignored them.
Right. Thank you. I completely agree with you, and you've brought a lot of great insight onto the topic. Before we end off, do you have any last remarks on the era of digitization, as it is called?
Well, I think it's a fascinating area,
hours.
a fascinating area to live in. I've been around, done quite a few interesting things. I almost died on multiple occasions where I've been in helicopter crashes, parachute crashes, things like that. So it's all been very interesting. But I think that, I mean, often people say, "Oh, they're terrible times," but in fact, the violence levels, the health levels, are probably superior to what they were certainly 50 years ago, let alone 100 or 200. But the trouble is, our standard rises every time, and we're suddenly realizing that we are all interconnected, and of course we'll probably have a very different society, I hope, and certain aspects of globalization will be gone, but we are all globally linked. So I think if we can learn from this and sort of apply, I think it'll, let's hope we have some sort of new awakening. One has to be an optimist.
Right, absolutely. Thank you for joining me on this conversation about the future of health and the era of digitization. And I hope to see you at our future events, Richard.
Okay, let's hope that October is a go and we're not virtual by then.
Exactly. That's what we hope so as well. Thank you once again.
Okay, thank you.